As we move through this, which is relatively a literature-free zone, I'll admit, I have no relevant disclosures to this talk. And so we know that spine fusion is kind of expanding, especially in the age group greater than 65, which is one of the areas where we really struggle with obtaining fusions. The cost of these fusions is also going up, as well as the cost of revision surgery. And so what is fusion? It's essentially a biologic race against time. So here's an L4-5 spondy. I was giving high fives and everybody was celebrating good fracture reduction, or good spondy reduction, good implant placement. And at 1 year, you can see my hardware failed. This lady was 55, she now has back pain, and I'm doing a revision surgery. And so when you think about why this happened, we think about lots of things. And so really when we think about systemic diseases and how they play a role in fusion, we want to think about what the critical elements of bone repair are. And so you essentially need an osteoinductive stimulus. You need something to bring the right responding cells to the area. You need a matrix on which bone can grow. And then finally, you need blood supply. And in a mouse, this happens over about 3 months. But in humans, it takes, anywhere from 9 to 15 months to make this happen. And so there are several key things. And so what do we optimize? Well, we heard about implants prior. We can optimize our bone fusion area as well as the local milieu. But when we think about the things that affect global bone metabolism, we think about systemic factors. And we think about nutrition, age, osteoporosis, infection, cancer, metabolic bone disease, and local environment. And we'll kind of walk through these. And so there haven't been a lot of studies that have looked at albumin or pre-albumin with regards to fracture healing and or spine fusion healing. But if you look at all the literature, people who are malnourished do poorly. They have higher 90-day readmissions, they have higher mortality, they have higher wound problems, and all that goes to say there's probably something making it hard for them to achieve the goals of surgery. And so this study in JOS in 2023 basically used the Pearl Diver database to compare groups of patients based on BMI. They classified underweight patients as less than 20 BMI and overweight greater than 40, and they propensity can match this to healthy controls with normal weight. And what they showed was that there was a higher risk of having a refusion at 1 year and higher implant complications or hardware failures at 1 year in these patients that are underweight. So obviously there's some interplay, whether that's low bone mineral density, whether that's not enough protein, whether that's less cells, it's hard to know. And so when we talk about vitamin D metabolism, I'll defer all questions to Dr. Patel. He wrote a great paper in 2013 with regards to vitamin D metabolism, and I don't really understand all of this, but I can tell you there's a lot of organs that are listed on this flow diagram, and vitamin D is crucial in bone metabolism and hemostasis. It controls calcium and phosphorus absorption out of the gut. It stimulates osteoclast activity, and it basically controls our ability to heal. Vitamin D or hypovitamin D is quite common, with rates as high as 80% in people that break their hip. It's higher in people with darker pigment skin. And the end effect in adults is osteomalacia, thinner cortices, weaker bone. And so for all patients that I'm doing a fusion on in clinic, they get a vitamin D pre-op to see if they're low, and then we do replace them. This is a modifiable thing that affects your ability to fuse. If you have continued repetitive non-unions, that's when you refer to an endocrinologist to see if there's a metabolic bone disease, because anything that can affect absorption, anything that can affect the kidneys or the gut can have an effect on this. And so when you look at vitamin D in terms of spine fusion, there's conflicting literature in the data. Dr. Daly and his group showed that there were higher rates of non-union as well as slower time to fusion. Dr. Donnelly and his group said that there was no difference. In the biggest study in another Pearl Diver database study in 2023 showed that vitamin D was associated with higher risk of reoperation at 1 year and higher risk of refusion at 1 year. And so it probably does have an effect. When we talk about age, these two are very, very different cases. I call pediatric orthopedics ballpark orthopedics because you can put it in the ballpark and they'll heal. It's very, very hard to get adults to heal. And so why is that? Well, if you think about the cellular makeup that we have in our marrow, it changes over time. And so this was a study done over the course of about 15 years by a single surgeon where they aspirated the anterior superior iliac crest and took out bone marrow, spun it down, and saw how many cellular progenitor cells were in the serum. And what they showed is that with age, you see a significant reduction in those mesenchymal stem cells. And so by the time you were 60, you had 1/3 of the biologic availability as you did when you're 30. And so what's in our blood, the cells capable of responding, changes over time, and that's a detriment to us. When we talk about cancer, why is cancer so bad for bone healing? Well, obviously there's the chemotherapy, there's the malnutrition, there's radiation. We can't really use some of the things that we typically use. People tend not to use local autograft because of the metastases. And the question is, can we use BMP? Well, we can have a whole session up here based on the history of BMP and all of the talk regards to does it cause cancer or not. Most of the recent literature says that there's no increased incidence in cancer, but because of the proposed risk, most surgeons won't use it in an active cancer patient or when you're treating cancer. And so what are the best bone graft options? Well, it's usually iliac crest bone graft and an anterior cage reconstruction, but that being said, you gotta make sure that there's no cancer in the iliac crest. And so this is really an area that you have to consider what bone graft options you have, and you're left with a lot of DBX and a lot of local cancellous allograft in order to achieve your goals. When it comes to osteoporosis, this is probably what all of us deal with on a day in, day out basis. It plays a major role in both structural supportive fusion as well as metabolic supportive fusion. And that's because as we get older, we have less cells that are capable of making bone. We have less responsive cells that work in that space. We have less vasculature to the area, and this really depends on where we're trying to get a fusion. Posterior lateral space has a lot of bleeding. When you go to the disc space, this isn't really a vascular area. And then we have dysregulation of signaling. And if you look at all the drugs that we use to treat, there's conflicting literature on whether they help or not. And I think we're still left wondering whether anabolic osteoporotic medicines assist in fusion. There's been some studies in the spine literature that say they do, or whether bisphosphonates hurt. But most of the literature says that these things don't affect it. But as you become more osteoporotic, you have less of a time to achieve fusion, and it may push you towards more aggressive bone graft selection. Diabetes is another systemic thing that affects bone growth. Diabetics tend to have slower fracture healing. So there was a mouse or a rat model developed in 2020 that showed that rats were slower to undergo fusion in the posterolateral lumbar space, and they had less robust fusion, and that probably has to do with glycemic control. The fact that there are a decreased number of osteoclasts versus osteoblasts in that area, it's a higher inflammatory state, and more stem cells are directed towards adipose tissues. So when you think about your cellular bank that you have less going towards bone and more going towards adipose tissue. So this is a group that's at risk for non-union. Smoking, NSAIDs, and drugs, again, this can be a whole session with regards to whether or not it affects spine fusions. The literature is pretty clear that smoking is bad. Whether it is something in the smoke or whether it is the nicotine itself is more controversial, and I think that's what we don't really understand yet. Dr. Su's done some great research on that in his lab. But for me, if a patient smokes, I'm not doing a fusion unless it's unavoidable. And if they do smoke, and I have to do it for something like cauda equina or progressive deformity, then I'm gonna do more aggressive bone graft techniques. I'm gonna take iliac crest, I'm gonna use BMP. NSAIDs, most of the literature says they're safe within the first 3 weeks of fusion. If you use them longer, they probably do a detrimental effect, but I'm not really changing my bone graft selection, and I actually use NSAIDs in practice. When we think about drugs, there are certain drugs that have been shown to affect your ability to fuse. Chemotherapeutic agents, methotrexate in super high doses, negative to bone health, but in a small dose, treatment of rheumatoid arthritis, it's really not a big deal. And so infection, now this is an interesting dichotomy. We know that there's a lot of asymptomatic infections in pseudoarthrosis. And so if you culture pseudoarthroses that occur in the body, this study in the bottom left was 130 patients. About 10% of them had culture-positive bacterial infections. And so there's some interplay between infection and maybe hardware loosening. But we all think that when infection is present, there's increased vascular supply. And I actually love doing fusions in the setting of osteodiscitis because I think they heal really well. It's probably because of that vasculature, the cytokines in the area, bringing those platelet-derived growth factors into the area that assist in fusion. Is there any contraindication to using BMP or these type of agents? A lot of the studies would say no. So in small series, again, we don't have large data, but in small series, there were no increased complications with the use of BMP in infection. And so based on the structural requirement to that surgery, I will use BMP sometime. So this is level 7 evidence. I think when you're an expert, it's level 6. When you're trying to be an expert, it's probably more like level 7. So how do I choose graft material, right? So there's lots of spine biologics out there. There's limited evidence for the efficacy, so it's a very hard world to sort through. I think you have to evaluate cost and you have to evaluate the host as well as the patient risk factors for fusion. So I kind of have an environmental hierarchy where we're going from pediatric patients to lumbar pseudoarthrosis. We're going from young healthy patients to that sick old patient who is on their 5th spine surgery. And so as I move down, I know it's going to be a tougher battle to fight. I will err, even though the iliac crest is not as robust in these older patients, I think it works great. And I will augment with BMP. Why does this matter? Well, if cost wasn't an issue, we would probably use BMP in everything. But the fact of the matter is this is one of the most expensive aspects of spinal fusion. And so as you think about this, you have to weigh the pros and cons. So in summary, we know what factors are important for healing of a fusion. As you think about systemic diseases, you want to think how they affect your osteoinductive factors, how they affect your bone scaffold, how they affect your availability of responding cells, and finally, your vascular supply. If you do have one of those disease states, you basically want to treat preoperatively if they're modifiable, and if they're not, you probably want to escalate on your rung of what bone grafts you're using to optimize fusion. Future directions are that we need to sort of have patient-specific bone graft materials that can sort of make up for what you're missing or what that disease is affecting. Thank you.